Welcome to the second module in the Waco Family Medicine Point-of-Care Ultrasound curriculum, POCUS for Women's Health. This module will focus on ultrasound skills used to assess pregnancy, pre- and perinatal clinical scenarios, and the use of ultrasound to examine female and gender-diverse patients with uteri, ovaries, and glandular breast tissue. You might be wondering why this women's health module is sequenced second in the curriculum, and there's a few reasons for that. Firstly, this is a POCUS skill that is often the introduction to bedside ultrasound for many students in medical school and certainly for family physicians and OB residents. It's also probably the most common reasons why one of our doctors here at Waco Family Medicine will order an ultrasound or grab one of our mobile units and take it to the patient's bedside. Gaining some familiarity with these skills will help us to avoid unnecessary formal ultrasounds, improve our understanding of pregnancy management, and teach a variety of translatable skills for later POCUS applications. Finally, another reason why I put this module so early in the curriculum is due to the established relationship between ultrasound and women's healthcare. In 1958, doctors Ian MacDonald, John McIvar, and Tom Brown published an article in The Lancet that included this picture, which is the first ultrasound image ever taken of a fetus inside the womb. Since then, the fields of medical sonography and the fields of obstetrics have grown side by side, and it's practically impossible to imagine a world now where the care of a pregnant individual wouldn't involve ultrasound. The first lecture today is going to focus on first trimester ultrasound findings. We'll talk about the indications for scanning a patient early in their pregnancy and the typical scanning protocol used to make assessments of maternal and fetal well-being. We'll also discuss what features are diagnostic of pregnancy and how to measure an accurate estimated gestational age and date of delivery. Lastly, we'll touch on the subject of pregnancy viability and review some images that can suggest poor or positive prognosis for each unique pregnancy. So why should we do a first trimester ultrasound? Well, there are more reasons to do it than not, really. Common indications include to confirm pregnancy location, diagnose early miscarriages, or concerns of viability, to look at fetal risk assessment, and more. And I know you've seen this slide before, but it's important to remember that because we're using POCUS, we have to ask a clinical question. I mention this because many times I find myself grabbing the ultrasound anytime I have a pregnant woman in clinic without having a true goal in mind, just because I want to see what's going on or show mom the baby on the inside. And while this can be a fun way to examine the patient and build a great relationship with them, the rigor of our evaluation is dependent on a couple of factors. And so we need to be cognizant of the clinical question that we're asking when we grab this technology. When setting up for a pelvic ultrasound, you and the machine should be positioned to the patient's right side whenever possible. The curvilinear probe should be chosen for transabdominal imaging, placed in the midline sagittal or transverse view to start, and the indicator should be pointed to the patient's right side or the patient's head. Transabdominal images are optimized by a full bladder, so push those fluids or consider filling up the bladder. For transvaginal ultrasounds, the setup is similar, but the patient should be placed in the dorsal lithotomy position and draped for privacy. The intracavitary probe should be properly sanitized, covered with a single-use cover, lubricated, and gently placed inside the vagina until the cervix is seen on the machine's display. I try to be as patient-centered as possible during these exams, and I'll often ask patients if they prefer to introduce the probe themselves to minimize patient discomfort. The indicator on the probe should be pointing towards the ceiling or anteriorly to start those exams. Let's talk about the basic technique for imaging the pelvic organs. Firstly, the probe is placed in the mid-sagittal plane, using the bladder as an acoustic window to see the uterus. Fanning helps bring the entire organ into view. I'll show you some images of what this looks like in a sec. After visualizing in the long axis, rotate the probe 90 degrees with the indicator pointed towards the patient's right side, and find that same structure in the short axis. Again, use the fanning motion to scan through the uterus completely to make sure nothing gets missed. Finally, image the adnexa by translating the probe laterally and rocking the probe. Sometimes, in thin patients, translating laterally will bring the ovaries and adnexa into view. However, more often than not, they're deeper structures that are obscured by bowel gas. So in this case, it's easier sometimes, paradoxically, to scan the right ovary from the left side of the body by scanning through the bladder and uterus and using those as acoustic windows since they conduct sound fairly well. The reverse is also true for the left ovary. Here are the key images of normal anatomy I want you to have inside your head. Here we see a curvilinear transducer footprint. Our indicator is on the left side of the screen corresponding to the patient's head. We see an anechoic structure representing the urinary bladder in the near field. I'll highlight that now for us here. Right, there's our urinary bladder. And then it's folding, the uterus is beneath it, folding over itself in this area here. The still image on the right shows a uterus, which I'll highlight in purple, and the bladder, which I'll highlight in blue. This is an aneverted uterus, and as the operator is fanning the probe, we see the uterus scan in and out of view as they sweep those ultrasound beams all the way through the uterus. So every now and then your uterus will be kind of straight along in a straight line, or sometimes retroverted, but this is a common position that we'll see the ultrasound in. The transverse view now shows the bladder and uterus in the short axis. The bladder is this rounded oblong structure here at the near field near the top of the screen, and the uterus is this circular structure that's a hypoechoic oval lying deep to the bladder. I'll highlight these on the still image over here in the blue and purple, just like we did on the previous slide. Notice again how with fanning the probe, we see the entirety of the organ from the cervix all the way up to the fundus. And if you pay close attention, you can even see an IUD in place, but we'll focus on how to find those later. There's a little glimmer of it right there at the end. Right there. When a patient's anatomy can hinder the transabdominal view, if the bony pelvis doesn't obscure too much, these are not usually technically difficult exams to perform. You can optimize your images by turning down the gain. Because we're using the bladder as an acoustic window, deeper structures get affected by posterior acoustic enhancement artifact. So turning down the gain will decrease the brightness, which sometimes obscures the anatomy of the uterus and other structures. So crank the gain down, and then also make sure to adjust your depth so that you get that best resolution possible. Don't forget to manage your bladder and fan slowly but deliberately all the way through the organ so that you can see the entirety of the anatomy. But just in case that wasn't hard enough, even with those tips to optimize your transabdominal imaging, there are some patients whose anatomy or their clinical acuity prevent transabdominal exams. And in these patients, we rely on transvaginal ultrasound to comprehensively examine these patients. A key takeaway from this series should be this. If you plan to practice OB and interpret your own ultrasounds, you need to develop familiarity and comfort performing transvaginal ultrasound. This will probably rely on you using some elective time to hone in on this skill during your residency. So let me know if you'd like to set up a rotation to do that. Additionally, introducing a new probe type and a location of scanning also opens up a new set of images and orientation. And so image orientation can be quite confusing, but we'll try to go over it here so that you understand what it is that you're looking at. Here is a sagittal view of the uterus using the intercavitary probe. A few things stand out immediately. First, the footprint of the transducer up here is much rounder, circular than the curvilinear probe. And we also see that our probe is much closer to the uterus. See this little space right in here. And the resolution is much higher. We can see structures in much more detail because of the higher resolution and closer length of travel for those ultrasound beams. There's no bladder in view, and that's because this patient has been asked to empty their bladder to help bring the uterus closer to the probe and aid our imaging. So in contrast to transabdominal scans where you want a full bladder, for transvaginal scans, it's best to have the patient empty their bladder before scanning. The indicator here for the probe is kind of obscured by this label, but here on the left represents the antero-superior position. And we see a uterus with its endometrial stripe right here, and the cervix is down here. And this may be some, air or something inside or fluid inside the vagina, or it might be a little Nabothian cyst. It's a little bit hard to tell on a static image. On a coronal or transverse view, the probe is twisted so that the indicator points towards the patient's right side. Generally, in an anteverted uterus, this makes structures near the probe become more inferior posterior, and if structures farther away from the probe become more superior anterior. but this is largely dependent on the angle of the probe and the way that the uterus is flexed in the body. And so it just takes familiarity with manipulating that probe to understand in what direction these structures are being traced. So now that we know what a typical uterine anatomy looks like, we can start to identify when gestations are present inside the uterus. The most sensitive test for pregnancy is a qualitative human chorionic gonadotropin test, or HCG. If positive, the patient should be considered pregnant until proven otherwise with imaging and quantitative assessments. Every now and then you'll get a false positive, but usually, in most cases, patients are presenting after a missed period or after having sex recently and with a positive HCG. And the question isn't really, is this patient pregnant, but where is the pregnancy? Is there evidence of a healthy intrauterine pregnancy as opposed to an ectopic or an anovulatory pregnancy or other unusual cases that could be dangerous to mom or the developing fetus? The utility of ultrasound now depends on its sensitivity detecting a developing embryo. So the question we start to ask is, if a patient is pregnant, when should I be able to see something inside the uterus? And the answer, like so many frustrating answers in medicine, is a resounding, it depends. So let's talk about why. When diagnosing early pregnancy, we have two sorts of paths that we can go down to help figure out what is going on and when we should see something inside the uterus. The first is using our beta-HCG discriminatory zone. And the second is using the estimated gestational age of the pregnancy to guide what we should expect to see. Let's talk about each of these briefly. The HCG is historically important, but now known to be more variable than previously thought. So ladies can come in with a whole wide range of HCG and a range of findings on the inside of the uterus. While we still use this number as a general rule, it's not known to be as effective at predicting when we should see a pregnancy on the inside of the uterus. Especially as a single data point with one HCG level at any given point in time, it's even less helpful than having a trend and seeing if that trend is rising or plateauing appropriately. This does differ some for transvaginal ultrasound and transabdominal ultrasound. So for transvaginal ultrasound, the accepted discriminatory zone is about 1500. And at that level, we should start to see something, perhaps just a gestational sac or even more inside the uterus. But like I said, it varies from patient to patient and situation to situation. Similarly, a transabdominal ultrasound varies quite a bit, but its level is as high as close to 5,000 before we really truly expect to see something on the inside. You can read more about this in the ACOG Practice Bulletin 193, which summarizes, the utility of the HCG discriminatory zone. Meanwhile, if we use an estimated gestational age, we should expect to see that, 4 to 5 weeks into a pregnancy, there should be a gestational sac present. At 5 weeks, we begin to see the yolk sac, and at 6 to 8 weeks, a fetal pole. But these numbers also are estimations, and oftentimes we come in with pregnants who don't have a really good menstrual history or don't have an exact date of believed conception, and so using the patient's menstrual and sexual history to guide what our expected appearance is on the ultrasound can also be diagnostically tricky. When we do see something, one of the first things we see is a gestational sac. The critical question here is this patient with a suspected pregnancy, is there evidence of a gestational sac inside the uterus? So as a reminder, gestational sacs are foreign byproducts of conception. They should be located on the inside of the uterus and have a fluid-filled or anechoic appearance. And every now and then you'll see a decidual reaction. What I mean by that is, if you look here, we see an anechoic sac on the inside of the uterus. This is a transvaginal view. And then we see the myometrium here, and we also see this kind of hyperechoic structure, this kind of double ring that's going around the anechoic gestational sac, and that's a decidual reaction. And that is showing the proliferation and interface between products of conception and the uterus as the developing pregnancy begins to grow inside. There's a set of criteria that we can use to identify features suggestive of true gestational sacs that do likely represent healthy early embryonic pregnancies inside the uterus. And then we also have the pseudo-gestational sacs, which will not necessarily follow these criteria. So the FEEDS criteria, or FEED5 criteria, stands for F meaning fundal. So we see this gestational sac in the uterine fundus and not lower in the uterus, closer to the cervix. It should be an elliptical or rounded structure without any sharp angles. It should be located slightly eccentric to the midline, although this can be hard to tell if you're not an experienced sonographer. You can see that decidual reaction I showed you on the previous slide. And the size should be at greater than 5 millimeters in diameter. So those 5 findings are suggestive of a true gestational sac and a likely early pregnancy. For comparison, this is what a pseudo-gestational sac can look like. So a pseudo-gestational sac is, as we see here, is not located in the fundus some of the time. It's not elliptical, it's more pointed and spear-like in this case. It is in the midline or not easily seen eccentric to the midline. Here, there's this kind of hyperechoic border, but there's really not a thick decidual reaction when you compare that to this side over on the right. And the size of the gestational sac we see over here is less than 5 millimeters, as opposed to greater than 5 millimeters, closer to a centimeter over here on the true gestation. Gestational sacs suggest but do not confirm an intrauterine pregnancy. And so while the FEED5 criteria are helpful for suggesting IUP, they are not diagnostic. So to be confident in our diagnosis, we have to visualize a yolk sac or a fetal pole. The yolk sac is a round hyperechoic ring that represents the first definitive sign of an IUP. So here we see this gestational sac, we see a wonderful decidual reaction here, and then the regular myometrium. And then right here, we see this circular hyperechoic ring structure. And this is what we talk about when we see a yolk sac. On the right side, here's a good image that's a dynamic kind of video image. And we see this yolk sac right here inside the gestational sac. Beautiful. The fetal pole is the next step of development of an embryo, and it's usually seen between 6 and 8 weeks estimated gestational age. The fetal pole represents a mass of cells adjacent to or replacing the yolk sac. So sometimes you'll see the yolk sac present, and sometimes you'll just see the fetal pole as that yolk sac involutes. And it's used for the most accurate ultrasound-based dating by taking the crown-rump length. The crown-rump length is measured in the mid-sagittal plane of the fetal pole, meaning we want to see it at its longest axis in a symmetric form. We take the longest dimension from the skin line to the opposite skin line, and if a yolk sac is present, do not include that in your measurement. To get the best accuracy, use the mean of 3 different measurements to calculate your crown-rump length and calculate your estimated date. Now, most machines will do this for you, but it is sort of helpful to remember that if you're trying to date a pregnancy and then compare it to a patient's LMP, remember that to get an estimated due date based on a patient's LMP, you take the first day of the LMP, subtract 3 months, and add 7 days, and that date of the following year is the patient's the estimated due date. So then you can compare. Now, if you have to calculate the crown-rump length into EGA by hand or manually, you can take the length of the crown-rump length in centimeters and add 6.5 to it, and that gives you a rough estimate of the estimated gestational age in number of weeks. But I won't expect you to remember that calculation. This is taken from the AIUM and ACOG and Society of Maternal Fetal Medicine recommendations, the consensus guidelines on redating a pregnancy using ultrasonography. So based on whatever initial measurement you have, whether that's the LMP or the early ultrasound, you wouldn't redate unless you get a significant difference of more than a week in early pregnancy, and then all the way up to 3 weeks for later pregnancies. And so that shows us that the earlier that we get these measurements, the earlier we date an ultrasound, the more accurate we are. So Fetal cardiac activity can sometimes be seen even in this pregnancy right here. This is kind of a grainy image, but if you squint and look sideways, I bet you can see that here we have a gestational sac. We have a beautiful little yolk sac over here to the left. And then we have this crown rump, or we have this fetal pole here with a good crown rump length if we wanted to measure that. And then right here, there's this subtle little flicker that we're seeing that represents fetal cardiac activity. Fetal cardiac activity is an early indication of fetal well-being and viability, and we'll talk about how we can use that clinically here in just a moment. It's standard practice to measure the fetal heart tones or the fetal heart activity at every antenatal visit. This is Strength of Recommendation C in the latest AFP guidelines on caring for pregnant women. Little evidence exists, though, to help us determine what value FHTs are other than confirming a current living IUP. So when we do this, we should, in the first trimester, be measuring these with M-mode and not with things like color Doppler, power Doppler, or any other sorts of high energy or high index ultrasound modes, because there is a theoretical risk to the developing embryo with those really fragile structures that if we impart too much energy, that we could damage the developing fetus. So using M-mode, we can then trace out this cardiac activity, this little flicker we saw on the previous screen, and then take a measurement between different cycles of that activity and calculate a rate. Now, one thing that can mess us up here is that there are different settings. So some machines will use a 1-cycle measurement and some will use a 2-cycle measurement. So here, this is a machine using a 1-cycle measurement. So we see the start of this little wave going up and then it comes back down. And then here, the next wave is starting. And so this machine is calculating based on just one measurement. In our clinic system, for example, we use a 2-cycle measurement on our mobile units in clinic. And so know that if you only measure one, it'll probably say that your heart rate is in the 300s or something like that. And you might need to go back and remeasure it to get a more accurate fetal heart rate. A cool piece of information I found while preparing this lecture was that even in symptomatic patients, so those patients that present to your clinic or to the hospital with bleeding or pain in early pregnancy, if you see an IUP with visible cardiac activity, that pregnancy has a 90% probability of making it to term. Now, this was in a large group of undifferentiated patients that included probably much lower risk patients than our patient population. So ours is probably not quite as predictive, but it is a reassuring sign that if we can see viable, visible cardiac activity inside the uterus, that we can be somewhat reassuring to our patients that at least as of right now, things look like they have a good probability of making it. Perhaps just as importantly, we should be able to recognize when the pregnancy or when the gestation that we're seeing inside of the uterus is not viable, and so we can counsel our patients effectively. Findings diagnostic of pregnancy failure include pregnancies that show a crown-rump length of greater than 7 millimeters and no heartbeat present. Also, if a patient has a mean gestational sac diameter of greater than 2.5 centimeters and no embryo present, that's diagnostic of an anovulatory or failed pregnancy. There's more specifics, including the absence of embryos with heartbeats after a gestational sac has been seen. I don't expect you to remember these numbers, but know that you need to be able to look them up and diagnose when a patient has a pregnancy loss. Now, on the other hand, these findings are not necessarily diagnostic of, but they do raise your clinical suspicion for early pregnancy loss. So if you see a fetus, there's a crown rump length that's measurable, but you don't see fetal cardiac activity, it could be that that's just really, really early and you happen to catch it before the resolution was high enough for you to be able to see that cardiac activity, but it is suggestive that might be a pregnancy that is not viable and will ultimately fail. Similarly, a large sac, but not quite meeting that 2.5 centimeter ratio, that does not have a yolk sac or fetal pole on the inside can be suggestive of an impending pregnancy failure as well. There's some other findings here that I'll let you read on your own, but it is important just to be mindful of these. And when you're looking and you see something that isn't quite as expected, pull up this reference so that you can make an appropriate counsel an appropriate plan for follow-up for your patient. I want to touch briefly on the medical legal environment of using first trimester ultrasound in clinic. First and foremost, I think our biggest consideration should be being patient-centered in our examinations. So making sure that we drape the patients appropriately, that we let them have support people in the room with them as they want, that we show them the things that they're interested on the ultrasound, or that we not show them things that they're not interested in, is vital to making sure that we're patient-centered and that we advocate for patient-centered policies in the environments where we work. Secondly, we should have a sensitivity to the various personal, social, cultural, emotional, spiritual beliefs that accompany first trimester ultrasound. So some patients will come in with very much desired pregnancies, and others will come in with unintended pregnancies. Some people will have a lot of emotions riding on the line about the determination of what we see on our ultrasound or the gender of the fetus on our ultrasounds. And those types of things are things that we should be mindful of and cognizant of as we provide care to a diverse group of patients. Lastly, the viability and non-viability risk profile, especially in the setting of recent legislation like the Texas Heartbeat Act, is probably going to make use of point of care ultrasound not the best use for these exams when we're trying to determine viability or non-viability or presence or absence of cardiac activity and things like that. Because that risk is so high and because there are implications that are very important for our patients, these are usually needing to be performed at the level of a formal ultrasound so that we can get the best, most accurate diagnosis and information and counsel our patients appropriately. So that is our ultrasound for the first trimester lecture. I hope that you can remember that we talked about some indications and how to do these scans appropriately. We looked at the anatomy of the uterus and pelvis in both transabdominal and transvaginal views. We talked about finding and diagnosing and dating an early pregnancy using the crown-rump length. We talked about looking for fetal cardiac activity and using M-mode as the most safe and accurate way to make that assessment early in pregnancy without damaging or posing risk to the fetus. We talked about establishing IUP viability, and we briefly hit on some of the medical legal considerations relevant to the first trimester ultrasound. Come back next lesson, and we're going to be talking about ectopic pregnancies and what some of those ultrasound findings might look like.